Thanks for coming to one of our many educational seminars we have through Chesapeake Urology. I'm Dr. Tom Huisman. I'll be speaking tonight first on erectile dysfunction. We will also have a talk from Dr. Chang following this on urinary incontinence and treatment thereof. I'll give you a little information on myself first. I was raised in the San Diego area. I went to the United States Naval Academy undergrad, and then the Navy was kind enough to put me through med school. So I went to med school at Georgetown University and then did my residency and internship at the Naval Medical Center in San Diego. And after that, I did 20 years in the Navy, was head of the major teaching program at Balboa in San Diego, where we taught residents a lot of the surgical techniques that we're going to be talking about tonight. After I retired in '97, I came out here and joined Dr. Chiaramonte and Dr. Zorn, and we were in practice for a number of years, and then we joined Chesapeake Urology, and we've had the opportunity to give these educational seminars. We now have access to a lot of the more recent and up-to-date techniques, and it's exciting to be able to talk to you tonight about some of the things that we're doing to treat both ED and urinary incontinence. First, we're going to talk about erectile dysfunction. We're going to cover a lot of things, a lot of which is already pretty common knowledge, but I'm going to touch on some of the reasons people develop erectile dysfunction, some of the conservative and then some of the more advanced treatments that we have over and above just pills to treat this problem. We define it as the persistent inability to attain and maintain an erection that allows you to have satisfactory intercourse. So that can include someone who gets an erection and then has the erection go down too soon. It can count patients who just can't get an erection at all with or without stimulation. It includes also premature ejaculation and things like that, which we may touch upon. It's a very common problem. 1 in 5 American men over the age of 20 has erectile dysfunction or has experienced some sort of erectile dysfunction episode in their lifetime. And more than half of men over the age of 40 have some degree of erectile dysfunction. Fortunately, I guess because of the attention it's getting on TV, men aren't suffering in silence anymore. They're coming up and asking their primary care physician and then coming to see us when need be. A little about the erectile process. It's a combination of neurological and vascular things going on. When the brain sends the signal with pleasurable arousal sensation to the penis, what happens is the blood vessels in the penis engorge and cause the two erectile bodies, which these are them in cross-section, but there are two cylinders in the penis that normally engorge with blood to allow for a firm erection. The blood vessels that supply the penis are two very delicate blood vessels that run alongside the prostate. And so those blood vessels can be affected before any other blood vessels in the body by things like atherosclerosis, diabetes, hypertension, things like that. So you may have no other manifestations and then suddenly start manifesting the fact that you can't maintain an erection. It's also intuitively, as you would guess, related to overall health. Sometimes we find that erectile dysfunction is the first symptom of something more serious going on. Diabetes, vascular disease, et cetera, et cetera. So when I see someone for erectile dysfunction, I'm thinking not only about the ED, but I'm thinking about, are there other things that may be going on that may have precipitated this problem? And so we it's kind of our job as overall clinicians to say, okay, we're going to treat that, but I'm going to make sure you don't have something else going on. So many times we may do screening tests for diabetes, prostate cancer, heart disease, things like that. Erectile dysfunction affects patients in a lot of different ways. It can affect your overall quality of life, and it just has a major impact across all of the spectrum. Diabetes is the #1 cause of erectile dysfunction in men, and it happens because of the small vessel disease. Diabetes is notorious for causing the blood vessels in the body to develop plaques and to interfere with blood flow. That's also a reason why many men who have diabetes can develop phimosis. If they're uncircumcised, the foreskin gets tight and becomes harder to retract, and that also can lead to erectile dysfunction in many instances. So many times what I'll do as a urologist when I examine a patient is we'll look at a urine to make sure they're not spilling sugar into the urine. We'll check labs to make sure that they're not running high blood sugars, and if they have diabetes, we'll look to make sure the diabetes is under control. Check your hemoglobin A1C, check your fasting blood sugars, et cetera, et cetera. Once more about diabetes, talking about the vascular disease. Patients who have diabetes, it's pretty important that, #1, we're going to treat the ED, but it's very important that you get the diabetes under control and keep it under control. We do that also for prevention of cardiovascular problems, et cetera, et cetera. The longer you have diabetes, the further it can progress and the more likelihood there is of developing erectile dysfunction. It's also very common in patients who have heart disease. a lot of patients who have either hypertension or heart disease are on a lot of medications. And so it always happens that a patient will come in to see me and they'll have started a new medication and they'll have erectile dysfunction. And many times, a lot of medications that are specifically used to treat the heart and blood pressure can adversely affect erections. The problem is you got to be on these medicines because you have to get these other problems under control. So we have to work around them. It's not simply a matter of stopping these medications. So we have to keep them going. We also screen patients for vascular disease, claudication. Just because the blood vessels to the penis are involved doesn't mean other blood vessels can't be involved too. And so patients may have problems with peripheral vascular disease, trouble walking distances without getting cramps in their legs, things like that. So these are all things that are important to get under control. Now, a lot of patients will ask me, well, the first thing they'll say is, well, we need to check my testosterone because I'm not getting good erections. Testosterone plays an important part in the erectile syndrome, but testosterone isn't the gasoline that drives the engine for erections, okay? Getting erections, like we talked about, is a vascular phenomenon. You have to have the blood flow, you have to have the flow through the pipes to get the penis hard and keep it hard. Testosterone is more a function of general well-being, sex drive, muscle mass, libido, things like that. So many times erectile dysfunction and low testosterone go hand in hand. But just because you have a low testosterone, if I replace that and fix it, that doesn't necessarily mean we're going to fix the erectile dysfunction. But we many times will check that as a problem. It's a very common coexistent problem, and 4 in 10 men over the age of 45 can have problems with testosterone levels. So we will undoubtedly check that, and if it is a problem, we can discuss replacing it. And these are the basic symptoms of hypogonadism or low testosterone. Men will experience easy fatigue, low sex drive, low energy levels. There may be loss of muscle mass. So there are a lot of advantages to replacing testosterone when and if a patient needs it, and we will certainly not hesitate to do that. When and if a patient has a low testosterone, you can't take a pill for it. The only way we can really safely replenish testosterone is through the use of patches or gels that are put on daily, or more recently we have new testosterone pellets that can be inserted that will give off normal doses of testosterone and keep you at a normal level for 3 to 4 months at a time. We're watching you very carefully to make sure you don't have side effects from it. We always check with your primary care physician before we consider doing that. But there are a lot of benefits to replacing testosterone in men who have low testosterone levels. So we talked a little bit about the vascular supply to the penis and how vasculogenic erectile dysfunction can happen. The vast majority of patients that I see develop erectile dysfunction because the blood vessels just are not carrying the load anymore. Another very important cause of erectile dysfunction is neurogenic or neurological erectile dysfunction, and this can happen in patients who've had major surgery or radiation therapy. The nerves that cause these blood vessels to dilate run in very close proximity to the prostate. So many men who've had prostate surgery, radical prostatectomy, robotic prostatectomy, sometimes radiation therapy, sometimes brachytherapy. These can affect the nerves. Now, it doesn't usually happen immediately with radiation therapy. That may happen over years as the nerves deteriorate. With surgery, it's more dramatic. Many times when I do prostatectomy on patients, we have to go through a pretty extensive penile rehabilitation program to kind of get those nerves working again. We will work on that, but sometimes, despite our best efforts, if there's a neurological problem, the erections don't come back as easily. This is a graph that shows the percentage of patients that can have erectile dysfunction associated with prostate cancer treatment, and it can be anywhere from 25 to 75% of men. Peyronie's disease is another not so commonly known cause of erectile dysfunction, but certainly a cause of discomfort and consternation in men. Peyronie's disease is not really a disease, I call it a condition, but it's a condition where scar tissue is laid down in the wall of the penis, and it happens inexorably kind of over years. And we don't really know what causes it, but the thought is perhaps microtrauma from intercourse or whatever can do it. You develop plaques in the wall. You remember the anatomy of the penis before, where you had those erectile bodies that normally fill with blood. Well, they're encased in a tight envelope that holds the blood, and that's called the corpus or the corpus cavernosum. The corpora can develop scar tissue, and so over years you may develop a gradual curvature of the penis. It may be painless at first, or it may be painful, but some patients can have a dramatic curvature. It can be up to 45 or 90 degrees, and that can cause pain both with that patient himself and with his partner with intercourse, as you can imagine. So we always examine the patient to make sure there aren't any Peyronie's plaques, and we'll ask you, if you get an erection, is it straight or is it bent? And if it's bent, there are treatments we have that are very successful in reducing the curvature and getting rid of this plaque. Sometimes they coexist. A patient will have both erectile dysfunction and Peyronie's disease. You can't really address one without addressing the other. And this just talks a little bit about the etiology of Peyronie's disease, but you can literally see that in some instances it can curve any way. It can come dorsally, straight back towards the head. It can go left, port, or starboard, as we used to say in the good old days. Either way, you can see some significant curvature. And if that happens, we can treat that. That's not going to be the main focus of my talk tonight, but we can talk a little bit about some of the treatments we have for that. And that's symptoms of Peyronie's disease. Many times, patient will start off with pain with erections. The curvature may progress over time. The pain is usually a sign that the plaque formation is ongoing. So when I'm going to treat Peyronie's disease, I may wait until the acute painful phase is gone so that you no longer get pain. All you have is a curvature. That tells me there's no more plaque being laid down, and I can go ahead and treat it, either with conservative treatments or injection treatments or any of a number of things. And this talks about some of the treatments that we have for Peyronie's disease. We can operate to remove the plaque or straighten the penis, or a new treatment that we have is called Xiaflex. They've been advertising it on TV. It shows a guy walking around the corner sideways, stuff like that. We actually inject a collagen-reducing medicine directly into the plaque, and it's very effective at reducing and fixing the Peyronie's disease. You start by talking with your primary care physician, and you let him know what's going on. And a lot of them are very good about educating patients and talking to you about some of the earlier and successful treatments. By the time I see a patient, usually he's been through the gamut of at least a number of different pills and possibly some other treatment options. So at that point, we go. As you can see across the bottom, there is a wide spectrum of treatments that we have for erectile dysfunction, starting conservatively and working our way up to the medicines that you've all heard about that have been around for about 25 years. The Viagra, the Levitra, the Cialis, Stendra. These are all medicines that were originally designed as heart medicines. They thought they could give it to patients to improve blood flow through the body and reduce the risk of heart disease. So they gave these medicines or samples thereof to a bunch of guys in a study, and they found that these medicines don't have any effect on the heart. But nobody in the study wanted to give the medicine back. And so they figured out that what it was doing is it was selectively dilating those two little arteries that we talked about down there that can cause erections. They all belong to a class of medications called PDE5 inhibitors. Phosphodiesterase 5 is a chemical that improves blood flow. We usually start with a pill. Viagra is the classic one. You take a pill about an hour before you want to have intercourse. It doesn't magically give you an erection, but it improves the blood flow enough so that you can attain and maintain the erection better. They're very effective as a first-line treatment. Most of them have minimal side effects. The only patients that I see that cannot take these are patients who have heart disease who carry nitroglycerin. Because if you pop a Viagra and a nitroglycerin at the same time, you will hit the deck and have some serious problems. It's too much of a good thing because of the vasodilation. But I have patients who have had heart transplants that don't have significant coronary artery disease that can take the medication. There are some side effects, usually very minimal, but some patients with Viagra have reported a blue-green kind of haze or color blindness noted. Fortunately, since most of the time it's nighttime, this doesn't matter. Some patients can experience a mild headache. Some people experience some reflux-type symptoms or back pain with the Cialis. There have been some other notes that have come out about perhaps the association of sudden blindness with patients who've taken Viagra. That's a condition called NAION, and it's a vascular phenomenon where suddenly the blood flow to the eye can get messed up. I've been practicing 30 years and I haven't seen it, but it's something to be aware of. And so that's why they say if you take a Viagra and you have any visual disturbances. There's also some new data that came out that says Viagra could conceivably be associated with melanoma in patients who take Viagra a lot and then go out in the sun. Well, once again, these studies were all based on millions of patients, and some of whom who developed these symptoms or had these problems develop had a history of taking Viagra. So there's not a one-to-one causation, and this has not really stopped me from prescribing the medication. We talked about the side effects. We talked about when to talk to your doctor if you have visual disturbances or any of that stuff. That's good. Vacuum erecting devices. These are a very non-invasive way of restoring erections. And in this case, it's a cylinder that can either be hand pumped or battery operated, where you place the cylinder over the penis. It creates a seal with the base of the penis, and when you pump it, it literally pulls the blood down into the penis. Then there's usually a band that can be applied from the base, around the base of the penis, that holds the blood there. These have been around in multiple different models for literally decades. You may see them on the internet. I don't think you even need a prescription to get them. They're useful, they work, they're non-invasive, and they don't cause complications, but they're kind of a pain, and they're bulky, and not a lot of guys stick with them for very long. But they sometimes can be used with other treatments. Like, there's no reason you can't take a Viagra, and if you're not quite getting as much of an erection as you want, you can supplement it with this. Once again, about the vacuum erection device, no real complications. Sometimes there can be some bruising from it. The vast majority of my patients, most of the time it's covered by Medicare. The vast majority of my patients will use it for a while, and then it'll go by the wayside. Urethral suppositories. These were exciting for a couple of years. It's a medication in its pure form called prostaglandin. Prostaglandin is a substance that's present normally in the body, and when it's in the circulation, it increases blood flow. It says, get blood down here now. So one way we have of delivering that is to take a tiny suppository that's inserted through the urethra, at the tip of the urethra, and then you push the little plunger, and it allows the suppository to drop off in the urethra, and it's absorbed through the urethral wall, and it gives you an erection in that way. It's useful, but it's once again, it's a little uncomfortable, and not a lot of guys that I've treated it with stick with it. There's another more effective way to deliver the medication to the erectile bodies, and that's to deliver the prostaglandin directly in there with a needle. This is the treatment. The penile injection therapy is the treatment that you hear about on the radio, the Boston Medical Group, the Men's Health Clinic, the patients where they say, we guarantee results. Okay, well, they're pretty darn right. That's what usually happens. The way we do it is we take a tiny needle, an insulin syringe, for those of you who are familiar with it, and we inject it through the base of the penis near the abdomen. So there are very few pain receptors there. Every single one of my patients that I talk to this about says, there is no way I'm sticking a needle in my penis. And virtually every single one of them, when I do it, they're like, I didn't even really feel that. You know, it's not a big deal. So once you get over the stigma of doing it, it can be done. It's literally an amazing effectiveness. We usually do test doses here in the office. Within usually about 5 minutes of giving a very, very tiny amount, you'll get a very efficient erection, and it usually lasts about an hour. The side effects of this treatment are minimal. There can be slight bruising at the injection site, so even in patients who are on blood thinners, it's not usually a problem. I have you hold pressure to the injection site for about a minute, and then you massage the penis to distribute the medication, and within 5 to 10 minutes, there is a very, very impressive erection. Useful. It can be done no more than once in a day, usually 2 or 3 times a week if necessary, and it's very effective. A lot of the places that market this, that's their only niche, if you will, their main bailiwick. So they'll charge a lot of money. You'll go in there, you'll walk out of there with a smile on your face after they do the test injection, and then they'll sell you a vial of medicine for $1,000. You know, we have our own pharmacy that makes it up in the Baltimore area. We don't make money from doing this, and they usually mix up the vials and send the syringes and the alcohol wipes as a packet, and it usually ends up being about $80 to $100 for a vial of 10 doses. So it's a very effective treatment, and I have a lot of patients who are on it, and it works very well. The ultimate treatment that we have is for patients who've tried, I've tried A, I've tried B, I've tried C, and they're all very good about going through the progression, and for whatever the reason, the injections no longer work. They can't take the pills because of side effects or because of expense. The treatment that we offer that's got the highest satisfaction rate is a penile implant or a penile prosthesis. In this case, with a penile prosthesis, we are replacing those corporal bodies that we talked about so that you no longer have to fill that with your own blood. We replace it with 2 cylinders which can fill with saline and to make the penis hard, and then there is a pump that we can seal down in the scrotum that allows you to activate the device. So you can see that these actually date back to the days of the early 1800s and the whaling days. They actually implanted whale bones into these cylinders or under the skin of the penis to make the penis hard. Probably around the 60s or the 70s, urologists developed what we called a semi-rigid prosthesis, which was a braided wire or solid silicone device that could be implanted in the two corporal bodies side by side that would virtually give you a permanent erection. But because they were braided wire and encased in silicone, they could be malleable. So you could bend it so you're not walking around with wood all day, but you can at least bend it down and things like that. Then as time evolved, we became more advanced in our ability to conceal the device so that now the main device that I'm implanting is a three-piece device. So it has the two cylinders in the penis. It has the pump down in the scrotum that you can't see, but it's kind of down between the testicles. And then there's a reservoir that we implant up behind the bladder that holds the fluid. And it holds a substantial amount of fluid so that when you pump the pump, it transfers fluid from the reservoir and into these cylinders and gives you an excellent erection with increase in both length and girth, which is a new thing that's happening with these prostheses. So I've put in hundreds of these, and I will tell you that it's a big step. It's not for everybody, but it's for those patients who've been pretty religious about trying all the other things, and it's just not working anymore. Once we put a prosthesis in, there's not any other way to get an erection. It's not like you can say, well, I'll have the prosthesis, but if I don't like it, I'll take it out and go back to my injections. You can't do that because when we put the prosthesis in, we're replacing those corporal bodies, the spongy tissue in there, with these cylinders. So that kind of gets squished aside. So a prosthesis is forever if you're going to use it. But those patients who get it, the satisfaction rate is better than 85% at 7 years. More than 85% of patients who've had a prosthesis would do it again or would recommend it to their friends. So it's a very effective way once the device is started. And this just shows what the device looks like. There are variations of it. We use the AMS device or the Boston Scientific. Here's the reservoir here, here's the cylinders, and then here's the pump. 97% of patients would recommend the penile implant to others. 98% of patients reported their erections were excellent or satisfactory, and 96% of partners associated this with better sex life and we're happy with it. One thing I caution my patients about is no one's going to give you what God gave you, okay? A prosthesis is not perfect. One difference is when you implant a prosthesis, the head of the penis that used to engorge doesn't engorge anymore. It's not getting that blood flow down there. But the penile prosthesis itself goes down to about the middle of the glands, so the entire length of the shaft of the penis is rigid and it works very well. Benefits of the penile implants. We talked about this a little bit. The operation takes about an hour to an hour and a half. We're doing them right here in our surgery center. It's an outpatient procedure. The way Dr. Chang and I implant them is we make a tiny incision at the base of the penis, kind of where the penis and the scrotum meet, and we can implant all three of the components through that incision. We dilate the penis to get the maximum size cylinders in to make sure it's the most lifelike erection we can have. So there's inevitably some bruising and some swelling associated with it for a week or so after the procedure. So you're pretty sore, but the stitches that we put in the scrotum just dissolve. Usually a patient can urinate without any problem after that, and within a week or two, the tenderness and swelling starts to go down. Usually at about 3 weeks post-op, I'll have the patient come back and we'll cycle the device and make sure it's worked and seating properly, and then I have the patient cycle the device every day, pump it up, keep it up for about 10 minutes, and then deflate it. And then usually a couple weeks after that, they can start using it for intercourse again. Most insurances cover this. Before we recommend it, we always make sure that your insurance will cover it and work very closely with our office staff here. It's a very common procedure. It's a very successful procedure, but it's a procedure. It ain't like getting your hair cut. There are complications that can happen with any surgery. The main risk that we worry about with a prosthesis is infection. If the prosthesis gets infected, it's an artificial device. It doesn't have its own blood supply. So all the antibiotics in the world may not get in there to cure it. So it's a dreaded complication. We make darn sure if you have diabetes that before we put you through surgery, your diabetes is under good control. We give you antibiotics before and after the procedure. We use meticulous sterile techniques. So overall, the infection rate is much less than 2% with one of these, okay? If it does get infected, we usually do a salvage procedure, take it out and replace it at a later time. There is a slight risk of malfunction. These devices have been literally used since the early 80s, and they are constantly making revisions to them to make them better. They're now implanted, they're embedded with antibiotics, so the risk of infection is lower. There's usually only one connection that we have to make, so we don't have leaks from the connectors anymore. The reliability of these devices is amazing, and more than 90% of them are still functional after 7 years. The beauty of most of these companies is if there is a malfunction, they'll replace it for free. There's a lifetime guarantee. You got to have an operation to fix it, but the AMS people and the Boston Scientific people stand by their product very well. So that's the gist of it. We offer the full gamut of erectile dysfunction treatments here, including, which we may talk about later, the new Gainswave you may have heard of, the shockwave treatments that we use for stones, we can use now for erectile dysfunction, and I may briefly mention that at the end of the evening, which we have too. It's still experimental, it's not FDA approved, so most insurances won't pay for it, but we offer it through our main office up in Baltimore, and I'd be happy to talk to that should the need arise. Thank you, it's been my pleasure. I will come back and I promise we'll answer any and all questions that you have. I'd now like to introduce my partner, Dr. Chang, who's our resident expert on female and male incontinence, reconstruction, and penile reconstruction, and Peyronie's.
Thank you for coming, everybody. I'm Dr. Chang. I work out of this office with Dr. Huisman. I went to medical school in Philadelphia at Temple University, and then I trained out in Midwest. After residency at the University of Missouri, I did further training in reconstructive urology, which involves things like trauma and prosthetics and male incontinence surgery. So I'm going to talk about male incontinence surgery. Specifically, we're going to talk about male stress urinary incontinence. What is male stress urinary incontinence and who has it and what causes it? So typically, it's not normal for a guy to be leaking urine. Unless you've had surgery to remove your prostate, or you've had some sort of instrumentation or some sort of trauma or a pelvic fracture which led to a disturbance in your urinary tract, a guy shouldn't have any urine leaks. What is stress urinary incontinence? So after your bladder fills, your bladder has a mechanism to keep you dry, and that's the sphincter. Guys who undergo prostate surgery, the prostate sits right next to that sphincter muscle. So once it gets removed, whether it's the nerve damage or the direct damage to the sphincter, it leads to a weaker muscle at the base of the bladder. Before, it was able to provide enough pressure to hold urine in this space. It's become weak, so you start leaking urine, and that's what stress urinary incontinence is. And if you cough, sneeze, lift something heavy, and you realize that there's some wetness, that's stress urinary incontinence. But that's not something that you should be having unless you've had some sort of pelvic trauma or you've had your prostate removed. But if you have urine leaks as a man and you've not had any prostate surgery or you've not had any other instrumentations, then it's probably another form of urine leak that's beyond the scope of this talk today. It's roughly about 50% of men who have undergone prostate surgery. It's roughly half. Guys who have undergone prostate surgery immediately sometimes will know whether or not they're leaking, and if it's a mild form of urine leak, oftentimes over a period of time it'll correct itself. But after 12 months or so, if you continue to have urine leaks, that's not going to get any better. This is what your bladder looks like. It stores urine. Here's your prostate. And right at the base is the muscle that I was talking to you about. That's the sphincter muscle, which coapts and does this to keep this intact so that nothing leaks out. Neurologic disorders, enlarged prostate, radiation therapy, and then trauma. Urine leaks is not something that's going to kill you. It's not like having cancer, but it's a result of surgery to remove cancer. It's quality of life issue, but if you're leaking so much urine that you know that you have this smell, you have this odor, it's very restricting to men because oftentimes they get depressed, they know that they have this problem and they don't want to go out and socialize when they could be socializing because they're more worried about, am I going to have an accident, get wet? So it's a big problem. It affects all parts of your life. So these are just numbers of how many people get diagnosed with cancer and just data. If you have stress urinary incontinence, you're going to know it right after your prostate surgery. Oftentimes, if you have mild form of incontinence, your function to restore dryness typically comes back within the first year. but not everybody is fortunate to gain that continence back. Depending on how much urine leaks that you have, there are different ways to treat this problem. Stress urinary incontinence is a mechanical problem, so it's not something that can be treated with medicine. It usually requires some sort of bulking or some sort of surgical intervention to treat this problem. Urologists are surgeons who treat this problem, and particularly doctors who do prosthetic surgery are the ones who typically deal with this issue. Let's say you just had your prostate surgery and you're starting to notice that you have some urine leaks. There's some behavioral modifications that we could do: reduce fluid intake. You plan out your bathroom breaks, but that's really not very satisfying for most men. And there's also other interventions like pelvic physical therapy to strengthen your muscle. And all of that is typically done within that first year. Despite those maneuvers, you could still be leaking urine. Ways that you can get around with this is oftentimes either wearing diapers, or there's catheters, or there's clamps that you can put on the penis, but it's not very satisfactory. Those are the methods that people have used in the past. If I see a patient and they're worried about this urine leak, some of the information that I typically ask are: how many pads are you using? Do you leak urine at night? So based on that, it's either you're a candidate for a male sling or an artificial urinary sphincter. They're both implantation surgery. So male sling is analogous to surgery that we do on female patients with stress urinary incontinence. It's basically a mesh device. It's like a hammock that goes inside your urethra, and it gives you support. So it basically augments that muscle where it just doesn't have enough support, so it gives it a lift, and that usually provides good enough support to give men who have mild stress urinary incontinence relief. And it's not a mechanical device, it's just a hammock, and it goes in there to support. The idea is to stop it, but it also gives you the ability to urinate on your own. So when your bladder becomes full, it still is able to generate some pressure, but it's not, so we don't put it in there so that your bladder can't overcome that pressure. But it has to be somewhat less than the pressure that your bladder is going to generate to push urine out. But in men who have just, you leak like a sieve, you're wearing like 3, 4, 5, 6 pads a day, then we place something called an artificial urinary sphincter. And basically, this is a mechanical device, but basically what it does is it's basically a band that's filled with fluid, goes around your urine tube, and it gives it compression so that it provides pressure so that you don't leak urine out that way. And it's a 3-piece device, just like the penile prosthesis. It's a little bit smaller, but you have a pump that sits inside your scrotum. Basically, when your brain senses that your bladder is full, you just give this device a few pushes, and then it opens up the device. It allows you to urinate. You don't have to do anything after that. It's self-timed so that it refills itself after 3 to 5 minutes, and it's very convenient. You don't have to deal with external appliances. Everything's inside. This device has also been around since the 80s. It's very durable. It could last potentially more than a decade. Patients who've had this done are very happy with the overall result. This is demonstrating the uplift support of a male sling. This is called an advanced sling. The sling is placed through your obturator canal, which is the pelvic bone, and it provides basically support in your pelvis like this. It's minimally invasive. Your incision is only about this big. The procedure takes about an hour to hour and 15 minutes to do. It's done here at our surgery center, and you get to go home the same day. Usually I don't leave a catheter in afterwards, but sometimes I may leave a catheter in for like a day. This is the artificial urinary sphincter I was telling you about. This is for the guy who leaks a lot of urine, leaking like 3, 4, 5, 6 pads a day. This is the cuff that goes around the urine tube, the urethra, and at rest, it stays compressed like that. And when you're ready to urinate or evacuate your bladder, you just give this pump that sits inside your scrotum a few squeezes. This opens up, and you're allowed to empty your bladder. Once that's done, there's mechanical forces here so that this device will close back up again after 3 to 5 minutes, so you'll be dry again. It's a surgery that takes minimal amount of time, it could be life-changing. And and even though we're not saving any lives here by making you dry, it could really potentially, change the quality of life. The thing that we worry about the most is infection. The infection rates are low with this both type of surgeries. It's less than 1%. But if you do get an infection, these devices have to be removed. But there's always also risk of injury to the urethra because we're operating near the urine tube. And then there's a postoperative urinary retention where you may not be able to urinate afterwards, but it's typically due to swelling, and that typically resolves after a short period of time. And it is another device that we're placing. It's not as traumatic as placing a penile prosthesis because we're not putting in a huge device, but it is something foreign, so you're going to have some postoperative pain. After a period of time, like decade or so, you can have malfunction, or with an artificial urinary sphincter, because you're compressing healthy tissue with this device, the area where it gets compressed, it atrophies or it shrinks. So sometimes we have to go back in there and replace that band to a smaller size. And then another thing is if you go in there and put in a device that's too small for your urethra, it could potentially erode into your urinary tract, which causes an infection. Then it has to be removed. It's a very convenient device to use. It's very safe. I've not had anybody who had major pain after the surgery, after the expected course. If anybody has issues with urinary incontinence, Dr. Huisman and I are here, and we could provide service.